Good night, everyone. I am Sharice Arjun, and tonight I'll be presenting on the World Health Organization CNS tumor classification and an introduction to the Neuro-Oncology lecture series for this block. These would be the subsequent topics that we would be doing in the upcoming weeks. So the WHO CNS tumor classification timeline, the key points are in 1979, the first edition of the World Health Organization CNS tumor classification was published. The second edition was released in 1993, and this incorporated advancements in immunohistochemistry. In 2000, the third edition was published, and in 2007, the fourth edition was released. In 2016, that fourth edition was revised and published. The fifth edition of the WHO CNS5 classification was published in 2021, and it incorporated recommendations of the C-IMPACT Now, that is the Consortium of Informed Molecular and Practical Approaches to CNS Tumor Taxonomy, not official WHO. Some of the worthy general features were tumors are classified by types, and some of which are divided into subtypes, and subtypes are actually variations of the parent tumor, while others are different grades of the tumor. The suffixes NOS, not otherwise specified, indicates that molecular testing was either not done, or that the results were uncertain. And NEC, not elsewhere classified, is used when there is non-concordance between histological features and molecular testing, or when results show non-canonical results, for example, as might occur with a new or emergent tumor type. Molecular alterations are integral to the accurate diagnosis of the CNS neoplasms, and the most common diagnostic findings are listed in the subsequent tables that I would be discussing. In the following sections, descriptions such as the histology and the molecular biology do not cover the gamut of each tumor. However, the link below refers to the definitive WHO classification publication. But in this presentation, excerpts are included to show where the tumors fit into the overall scheme and to highlight some features that might be of relevance when treating patients with these conditions. So going into the classification groups, with regards to gliomas, glioneural tumors, and neuronal tumors, with diffuse gliomas, it was separated into adult and pediatric diffuse gliomas, and the pediatric types were further divided into pediatric type diffuse low-grade gliomas and pediatric type high-grade gliomas. Adult type diffuse gliomas were divided into astrocytomas, IDH mutant, with grades up to 4, oligodendrogliomas, IDH mutant, and 1P or 7 or 19Q co-deleted, again up to grade 4, and glioblastoma, IDH wild type, with giant cell glioblastomas, gliosarcomas, and epithelioid glioblastoma. Circumscribed astrocytic gliomas were divided into pilocytic astrocytomas, high-grade astrocytoma with piloid features, pleomorphic xanthosarcocytomas, subependymal giant cell astrocytomas, chordoid gliomas, and astroblastomas. And then there are the glioneural and neural tumors listed below, and ependymal tumors. Choroid plexus tumors included the choroid plexus papillomas, both atypical and typical, and choroid plexus carcinomas, and embryonal tumors were the medulloblastomas, which were molecularly defined and histologically defined. Other CNS embryonal tumors were added, such as atypical teratoid or rhabdoid tumor, cribriform neuroepithelial tumor, embryonal tumor with multi-layered rosettes, CNS neuroblastomas, and CNS embryonal tumors, NEC or NOS. Pineal tumors included the pineocytomas or pineal parenchymal tumors, and then there were pineal region tumors of uncertain cell origin and pineal region tumors of non-pineal cell origin. Cranial and paraspinal nerve tumors were divided into schwannomas, neurofibromas, and perineuromas and hybrid nerve sheath tumors, malignant melanocytic nerve sheath tumors, and malignant peripheral nerve sheath tumors. Meningiomas were subcategorized into meningothelial meningiomas, fibrous meningiomas, transitional, psammomatous, angiomatous, microcystic, secretory meningiomas, lymphoplasmacyte-rich meningiomas, metaplastic, chordoid, clear cell, rhabdoid, and papillary, atypical, and anaplastic or malignant melanomas. Mesenchymal and non-meningothelial tumors involving the CNS were divided into soft tissue tumors. Then there were the fibroblastic and microfibroblastic tumors, vascular tumors, skeletal muscle tumors, tumors of uncertain differentiation, and chondro-osseous tumors or chondrogenic tumors or notochord tumors. The melanocytic tumors were divided into diffuse meningeal melanocytic neoplasms and circumscribed meningeal melanocytic neoplasms. The hematolymphoid tumors involving the CNS were the CNS lymphomas, as seen in the table below. And there were some miscellaneous rare lymphomas in the CNS, such as the Molt's tumors of the dura, or the low-grade B-cell lymphomas of the CNS, anaplastic large cell lymphomas, T-cell lymphomas, and KT cell lymphomas, and the histiocytic tumors and germ cell tumors as listed below. Tumors of the cellular region were divided into tumors of non-pituitary origin, tumors of the posterior pituitary gland and infundibulum, and tumors of the anterior pituitary gland, or the pituitary adenomas, pituitary neuroendocrine tumors, or PITNETs. And lastly, the mets to the CNS were also included to include metastases to the brain parenchyma, the spinal cord, and metastases to the meninges. So the general changes in the terminology and taxonomy, the words entity and variant have been replaced for example, with glioblastoma isocitrate dehydrogenase wild type is a rare tumor, and it is many morphological variants are now listed as subtypes. CNS WHO grades previously listed in Roman numerals are now in this classification listed in the Arabic numerals, and integrated diagnoses combining both histological and molecular features, for example, astrocytoma IDH mutants, are now recommended. Layering reports to include integrated diagnoses and histopathological classification, and CNS WHO grades are relevant, and relevant molecular information is recommended. And grading is now done within tumor types rather than across the types. For example, with astrocytoma IDH mutant is assigned a CNS grade of either 2, 3, or 4. So the molecular characteristics are incorporated into the classification and grading of more tumors than in the previous editions, and the Human Genome Organization, or HUGO, gene nomenclature classification system is used for gene symbols and names, and the Human Genome Variation Society recommendations for gene variants and the International System of Cytogenic Nomenclature recommendations for copy number variants. 19 new and 3 provisional tumor types are included and described. So the major salient changes in these classifications are the separation of the low-grade and high-grade pediatric type diffuse from adult type diffuse gliomas, the recognition of several new ependymal, embryonal, and other tumor types, and assigning the CNS WHO grades within tumor types, pointing the most malignant IDH mutant diffuse astrocytic tumor as an astrocytoma IDH mutant CNS WHO grade 4, changing the name to diffuse midline gliomas or DGM H3K27M mutant into DGM H3K27 altered. So now I would move on into an introduction to the Neuro-Oncology lecture series. Within the upcoming weeks, we would delve into the individual tumor types and go a little deeper into the WHO CNS5 tumor classification. So pediatric brain tumors, all childhood cancers, amongst all of them, the brain tumors are the second to only leukemias, and they are the most common solid pediatric tumors, comprising of 40 to 50% of all tumors. The annual incidence of CNS tumors by age is shown as in the table below. In the 0 to 4 age group, there's an incidence of 6.3 per 100,000. In the 5 to 9 age group, 5.9%, and in the 10 to 14 age group, 5.94%, and 15 to 19 age group, 7.32 per 100,000 incidence. The common pediatric brain tumors with ages under 20 years are gliomas and neuroglial tumors in the cerebellum, brainstem, and optic nerves. Embryonal tumors account for 12.3%, 67% of which are medulloblastomas, pituitary tumors, nerve sheath tumors, and craniopharyngiomas. And amongst the pediatric population, the incidence of the following tumors decrease as the age increases. These are the pilocytic astrocytomas, malignant gliomas, ependymal tumors, choroid plexus tumors, and embryonal tumors. With regards to infratensorial versus supratensorial tumor location, it has traditionally been taught that most of the pediatric tumors, approximately 60%, are infratensorial, and that these are equally divided amongst brainstem gliomas, cerebellar astrocytomas, and medulloblastomas. In reality, the ratio of supratensorial to infratensorial tumors is dependent on the specific age group studied, as we could see in the table to the top 35.3. And in the 0 to 6 months age group, 27% of infratensorial tumors, 6 to 12 month age group, 53%, the 12 to 24 months, 74% incidence, and the 2 to 16 years of age, 42%. The table below shows the histological breakdown for infratensorial versus supratensorial tumors, and astrocytomas are the most common supratensorial tumors in the pediatrics and as well as in adults. So focal neurological deficits associated with brain tumors. In addition to non-focal signs and symptoms, for example, seizures or increased ICP, as with any destructive brain lesion, tumors may produce progressive deficits related to function of the involved brain. Some of the characteristic syndromes would include, as it pertains to the frontal lobe, abulia, dementia, personality changes, often non-lateralizing, but apraxia, hemiparesis, or dysphagia with dominant hemisphere involvement may occur. As it pertains to the temporal lobe, auditory or olfactory hallucinations, deja vu, memory impairment, contralateral superior quadrantopsia may be detected on visual field testing. And as it pertains to the parietal lobe, contralateral motor-sensory impairment, homonymous hemianopsia, agnosia with dominant hemisphere involvement, and apraxias may occur. With occipital lobe lesions, the contralateral visual field deficits, alexia, or especially with corpus callosum involvement with infiltrating tumors, and as it pertains to the posterior fossa, cranial nerve deficits, ataxia, which could be truncal or appendicular, and seizures generally do not occur with isolated posterior fossa lesions. Headaches with brain tumors. So headaches may occur with or without elevated ICP, and they are present equally in patients with primary or metastatic tumors. They are described as being worse in the morning, and this is possibly due to hyperventilation during sleep. And they are exacerbated by coughing, straining, or bending forward or placing the head in a dependent position. It's associated with nausea or vomiting in 40% and may be temporarily relieved by vomiting, possibly due again to hyperventilation during vomiting. These features and the presence of a focal neurological deficits or seizures were thought to differentiate tumor headaches from other types of headaches. And in 77% of brain tumor patients, they had similar headaches to tension headaches, and in 9% were migraine-like. 8% showed a classic brain tumor headaches, with 2/3 of these patients having increased intracranial pressure. So the etiologies of tumor headaches: the brain itself is not pain sensitive, and headaches in the presence of a brain tumor may be due to any combination of the following things. So increase in intracranial pressure, which may be due to tumor mass effect, hydrocephalus, which could be obstructing or communicating, mass effects from associated edema, mass effects from associated hemorrhage. There can be invasion or compression of pain-sensitive structures such as the dura, periosteum, the blood vessels, or cranial nerves with sensory function. There can be difficulty with vision, and this can cause headaches where there's diplopia due to dysfunction of cranial nerves controlling extraocular muscles. So when there's direct compression of cranial nerves 3, 4, and 6, and abducent nerve palsy from increased ICP resulting in diplopia, and the internuclear ophthalmoplegia due to brainstem invasion or compression, and difficulty focusing due to optic nerve dysfunction from invasion or compression. Extreme hypertension resulting from increased ICP, such as part of the Cushing's triad, and psychogenic as well due to stress from loss of function of capacity, for example, when there's deteriorating job performance. With regard to supratentorial tumors, the signs and symptoms are similar as discussed before. So those due to increased ICP could be from mass effect of the tumor or edema, or from blockage of CSF drainage leading to hydrocephalus. It is less common in supratentorial tumors when compared to infratentorial tumors. There's progressive focal deficit, and this includes weakness, dysphagia, which occurs in 37 to 58% of patients with left-sided brain tumors. And this is due to destruction of the brain parenchyma by tumor invasion, due to compression of the brain parenchyma by mass or peritumoral edema or hemorrhage, and due to compression of the cranial nerves. Other symptoms include headaches, seizures, which are not infrequently the first symptom of a brain tumor. Tumors should be aggressively sought in an idiopathic first-time seizure in a patient greater than 20 years, and if negative, the patient should be followed up with repeat studies at a later date. Again, as I mentioned before, seizures are rare in posterior fossa tumors or pituitary tumors. There can be also mental status changes such as depression, lethargy, apathy, or confusion, and symptoms suggestive of a TIA or dubbed tumor TIA or stroke may be due to occlusion of blood vessels by tumor cells, hemorrhage into the tumor, or a focal seizure. In the special case of pituitary tumors, symptoms due to endocrine disturbances pituitary apoplexy, and CSF leak. So when booking a case, uh, or for a craniotomy for supratentorial tumors, we want to take into consideration the location of the tumor, as this would help in planning the position and determining where the craniotomy would be. You'd want to consider if you want to do preoperative embolization for some of the vascular tumors, including some meningiomas, and you'd want to ensure that your equipment is procured, such as the neurosurgical microscope, ultrasonic aspirator, and image guidance systems, the availability of blood, an ICU bed, and consent in layman terms to the patients, including the procedure, alternatives, and complications. With regard to infratentorial tumors, the signs and symptoms would include headaches, nausea and vomiting, again due to either increase in ICP or from hydrocephalus or from direct pressure on the vagal nucleus, or in the area of postremia, which is the vomiting center. You can have papilledema. Estimated incidence is 50 to 90%, and gait disturbances or ataxia, vertigo, and diplopia. Signs and symptoms indicative of mass effects in various locations within the posterior fossa would include lesions in the cerebellar hemisphere can cause ataxia of the extremities, dysmetria, or an intentional tremor. Lesions of the cerebellar vermis may cause a broad-based gait, truncal ataxia, or titubation, and brainstem involvement usually results in multiple cranial nerve and lung tract abnormalities and should be suspected when nystagmus is present, especially rotatory or vertical. So evaluation of the patient with a posterior fossa infratentorial tumors in the pediatric patients with a posterior fossa tumor, an MRI of the spine should be done preoperatively to rule out drop mets, as post-op there may be artifacts from blood, and in adults, most intraparenchymal posterior fossa tumors will be metastatic, and a workup for a primary should be undertaken in most cases. So treatments of the associated hydrocephalus. So in cases with hydrocephalus, as the time of presentation, some authors advocate initial placement of a VP shunt or an EVD prior to definitive surgery. That is waiting approximately 2 weeks before surgery because of the possibility of lowering operative mortality. Theoretical risks of using this approach usually include the following. So placing a shunt is generally a lifelong commitment, whereas not all patients with hydrocephalus from a posterior fossa tumor will require a shunt. Possible seeding of the peritoneum with malignant tumor cells, for example, with medulloblastomas, and consider placement of a tumor filter, which may not be justified given the rate of filter occlusion. And some shunts may become infected prior to the definitive surgery. Definitive treatment is delayed, and the total number of hospital stays may be increased. An upward transsensorial herniation may occur if there's excessive or rapid CSF drainage. Either approach, shunting followed by elective posterior fossa surgery, or semi-emergent definitive posterior fossa surgery is acceptable. At Children's Hospital of Philadelphia, dexamethasone is started and the surgery is performed at the next elective operating day unless neurological deterioration occurs necessitating emergency surgery. In some of the surgeons place a ventriculostomy at the time of surgery, and CSF is drained only after the dura is opened to avoid upward herniation and to help equilibrate the pressures between the infra and supratentorial compartments. Post-op, the external ventricular drain is usually set at a low height and for 24 hours and is progressively raised over the next 48 hours and should be discontinued by about the third day post-op. And with booking a case for infratentorial tumor, similar things we would take into consideration, keeping in mind based on the location, you would want to position the patient based on surgeon's preference, typically either in the prone, on Mayfields, or in a park bench position, depending on the tumor type, location, and again, surgical preference. So how do we manage patients with brain tumors? In the initial evaluation and management, the approach to a patient with a newly demonstrated or suspected brain tumor, we would look at imaging first, obtain an MRI of the brain with and without contrast. A CT with and without contrast is an alternative if MRI is not available or if it is contraindicated. Ensure that a navigation compatible sequence is included for possible surgery. And if the lesion is likely a pituitary tumor, an MRI of the brain with pituitary protocol with and without contrast should be obtained. A metastatic workup is obtained if there's a possibility that the lesion could represent a metastasis, and the indications would be multiple brain lesions, a solitary round ringing Hansen lesion at the interface between the gray and white matter, or in the posterior fossa of an adult, and suspicion based on the history given, for example, if the patient is known to have cancer or symptoms suggestive of cancer, such as unexplained weight loss or other constitutional symptoms. If the suspicion of metastases is low or a craniotomy needs to be done urgently, the metastatic workup can also always be deferred until the craniotomy and then undertaken if the pathology from the surgery is consistent with metastases. Obtaining imaging of the entire neuroaxis, that is the spine, with and without contrast, in addition to the brain, to rule out drop mets for pediatric patients, as we would have mentioned before, and specialized imaging such as diffusion tensor imaging or DTI, MRI, functional MRI, cerebral angiography are usually obtained subsequently based on a number of factors obtained during the initial evaluation phase. For CP angle tumors, Fiesta MRI and audiology screening should be obtained, and if cerebral abscess is suspected, an infectious workup should be performed. So the role of steroid use in brain tumors. The beneficial effects of steroids in metastatic tumors is often much more dramatic than with primary infiltrating gliomas. Dexamethasone or Decadron dose for brain tumors for patients not previously on steroid for the adult patients would be 10 milligrams IV loading, then 6 milligrams PO or IV Q6 hourly. And in cases with severe vasogenic edema, doses up to 10 milligrams Q4 hourly may be used for a short time space, that is 48 to 72 hours. In the pediatric population, the regime is as on the slide. And for patients already on steroids, for acute deterioration, a dose of approximately double the usual dose should be tried, and this is known as the stress dose. And patients on steroids, of course, should receive prophylaxis against Cushing ulcers. Prophylactic anti-seizure medication and its role with brain tumors. 20 to 40% of patients with brain tumors will have had a seizure by the time their tumor is diagnosed. Anti-seizure medications are indicated in patients who have had a seizure. 20 to 45% more will ultimately develop a seizure, and prophylactic anti-seizure medications do not provide substantial benefits. Prophylactic anti-seizure medications are not indicated for isolated posterior fossa tumors due to the fact that tumors in this area themselves have a low risk in provoking seizures. So the practice guideline for prophylactic anti-seizure medications, the level 1 evidence, is that prophylactic anti-seizure medications should not be used routinely in patients with newly diagnosed brain tumors. And level 2 evidence, in patients with brain tumors undergoing a craniotomy, prophylactic anti-seizure medications may be used, and if there has been no seizures, it is appropriate to taper off anti-seizure medications starting 1 week post-op. So surgical intervention and surveillance mode. Almost all tumors require surgical intervention. Exceptions include situations with an extremely high confidence diagnosis or slow-growing benign lesion based on imaging. For example, many meningiomas or asymptomatic central neurocytomas, in which case surveillance mode with serial imaging and monitoring of symptoms is employed. The goals for surgery are usually cytoreduction, that is maximal safe resection, with the goal of gross total excision when feasible, but at a minimum for biopsy for diagnostic, prognostic, and treatment planning purposes. For appropriate tumors with low suspicion of malignancy, again, such as many asymptomatic meningiomas, asymptomatic hormonally inactive pituitary tumors, they use with caution with suspected low-grade gliomas, as some of these may be high-grade or encephalitis. An initial follow-up imaging study is usually performed at about 3 months after the initial study, and this is called the stability scan, to rule out rapid growth. And if stability is demonstrated, studies are performed annually thereafter, unless if there's a change in symptoms that prompts an earlier or repeat scan. So moving on to chemotherapy agents for brain tumors. I'll start with the alkylating agents, and the most common here is temozolomide, an oral alkylating agent, and is a derivative of TTIC. It is a prodrug which undergoes rapid non-enzymatic conversion at a physiological pH to the active metabolite of MTIC, and the mutagenic or cytotoxic effect of this is associated with alkylation to DNA at various sites, primarily at O6 and N7 positions on guanine, and cells can repair this damage via the O6 methylguanine DNA methyltransferase, a protein which can be deficient to some degree in various tumors, especially astrocytomas, IDH mutants, which renders them more susceptible to temozolomide. The nitrosoureas, they have excellent blood-brain barrier penetration. However, they have significant hematopoietic, pulmonary, and renal toxicity. So this table here to the right shows the therapeutic agents used for CNS tumors. The agents are located on the left side of the table, and their mechanism of actions are on the right column. So the blood-brain barrier and chemotherapy agents. Traditionally, the blood-brain barrier has been considered to be a major hindrance to the use of chemotherapy for brain tumors. And in theory, the barrier effectively excludes many chemotherapeutic agents for the central nervous system, thereby creating a safe haven for tumors, for example, METs. This concept has been challenged, and regardless of the etiology, the response of most brain tumors to systemic chemotherapy is usually very modest, with a notable exception being the favorable response of tumors with deficient MGMT activity. So the considerations regarding chemotherapeutic agents in relation to the blood-brain barrier include some CNS tumors may partially disrupt the blood-brain barrier, especially malignant gliomas. Lipophilic agents such as the nitrosoureas may cross the barrier more readily. And selective intraarterial, for example, intracarotid or intravertebral injections, produce higher local concentration of agents, which increases penetration and with lower associated systemic toxicities than would otherwise occur. And the barrier may be iatrogenically disrupted, for example, with mannitol prior to administration of the agent. and it may be bypassed by intrathecal administration of agents via lumbar puncture or ventricular access devices, such as methotrexate for CNS lymphomas, and biodegradable polymer wafers containing a chemotherapeutic agent may be directly implanted. So imaging studies following surgical removal of tumors. At many academic centers, it is common to get a non-contrast scan within 6 to 12 hours of surgery to assess for acute complications. These are primarily hematomas, intraparenchymal, epidural, or subdural, or the amount of pneumocephalus or hydrocephalus, and then to assess the extent of tumor removal, a post-op MRI brain or CT if MRI cannot be done with and without contrast should be obtained within 2 to 3 days, or should be delayed at least 30 days after if that window period is missed. The non-contrast scan is important to help differentiate blood from enhancements, and the contrast agents. The contrast images demonstrate areas of enhancement, which may represent residual tumor. So as a result of inflammatory changes due to surgery, the enhancement increases at the wall of the resection bed within 24 to 48 hours of surgery, and this is the so-called post-operative changes. After this 48 hours, one cannot reliably differentiate contrast enhancement due to postoperative changes from residual tumor, and this usually subsides by 30 days but may persist for 6 to 8 weeks postoperatively. The effect of steroids on contrast enhancement is controversial and may depend on many factors, including the tumor type. So moving on to the pathology aspect of it, intraoperative pathology consultations with regard to frozen sections. The accuracy of intraoperative pathological diagnosis can be increased by providing the pathologist with information regarding the patient's demographics, clinical history, imaging results, relevant previous pathological diagnoses, and the clinical presentation, and large specimen sizes when possible, and avoid artifacts created by excessive crushing or coagulation. With regard to touch preparations, the specimen is gently touched with a glass slide, which is then rapidly fixed, stained, and dehydrated for examination. This technique is particularly used for tumors with discohesive cells, for example, lymphomas or pit nets, lesions or adenomas. And smear or squash preparations, a small portion of the specimen is smeared or compressed with moderate pressure between the two glass slides and rapidly fixed, stained, and dehydrated for examination. This technique can be particularly useful for multiple sclerosis. The cohesive nature is often seen in tumors such as METs and meningiomas. This is apparent and areas of necrosis. So these smears are good for cytology, but they don't show architecture, and they preserve more tissue for permanent pathology than frozen section. The benefit of frozen section is that it is better for tumor architecture, but it creates artifacts and uses more tissue. So at the time of frozen section, interpretation, consideration for additional studies such as tissue cultures or flow cytometry should be entertained, and with minute specimen, a discussion is warranted whether frozen section is required to preserve tissue for permanent studies. So selected frozen section pitfalls or potential critical diagnosis. Differentiating low-grade gliomas from normal or reactive brain tissue can be challenging. Increased cellularity, which is best evaluated at low power, nucleotypia when present, and increased perineural satellitosis can be helpful, though not always readily observed. And with regards to metastases versus gliomas, it's usually not problematic on frozen section, except occasionally with marked atypical gliomas with limited sampling. And in such rare cases, immunohistochemistry is helpful. So I'll focus on specific lesions. So astrocytomas versus oligodendrogliomas, usually not a critical distinction at the time of frozen section diagnosis. However, in part due to frozen section, artifact imparted to the nuclei, and oligodendrogliomas can be interpreted as astrocytomas on frozen section. Smear preparation can at times be helpful due to decreased freezing artifacts, and also perineural satellitosis may be, in some cases, more pronounced in oligodendrogliomas. In the WHO CNS5, the distinction is dependent on molecular genetics. With regard to glioma grading, the sampling bias, particularly in a small biopsy specimen, can lead to undergrading, and that is underrepresentation of the mitotic figures, vascular proliferation, or necrosis in the biopsy specimen, and conversely, overgrading of gliomas at the time of intraoperative consultation can occur, including with low-grade childhood gliomas such as pilocytic astrocytomas. With regard to radionecrosis versus recurrent tumor or higher grade astrocytomas or glioblastoma, despite the fact that a history of prior radiation therapy is usually known at the time of intraoperative consultation, differentiation of the two entities can be at times be difficult. Both lesions are often present simultaneously, and identifying obvious tumor cells and palisading necrosis suggests recurrent or residual glioblastoma. Radiation necrosis, which affects primarily the white matter, is supported by large geographic areas of necrosis, sclerosis, hyalinization, and of the vessels or fibrinoid necrosis of the vessel walls, perivascular lymphocytes, calcifications, and the presence of macrophages. Small cell carcinomas and lymphomas, these two entities may resemble each other on frozen section as well as resembling astrocytomas, oligodendrogliomas, and other types of metastatic carcinomas. Touch preparations can be particularly useful in identifying pediatric CNS lymphomas. With regard to meningiomas versus tumors with spindle cells, distinguishing between the two can be difficult, again, during the interop classification, consultation, sorry. Classic features of meningiomas are the whorls, the samoma bodies, the intranuclear pseudoinclusions may be absent, and the freeze artifact can create areas that resemble Anthony B fibers. In addition, underdiagnosis of malignant meningiomas and sarcomas at the time of frozen section has been noted. Spinal cord astrocytomas and ependymomas, due to the critical surgical implications of the accuracy of frozen section, the diagnosis for intramedullary spinal gliomas. A careful discussion should be had between the surgeon and the pathologist in the time of the intraoperative consultation. So tissue preparation for permanent section, the slides just shows some of the steps that can be followed. These select commonly utilized stains in neuropathology. There can be organism stains or special stains, and I'll just make mention of a few. So the organism stains would include the tissue gland stains, such as the Brown and Bren or the Brown and Hops, the fungi or periodic acid skip, or the gomori, metamine, silver stains, or the acid fast bacilli with Seal Nelson or Quinion or Fit. And then there are the special stains such as the Luxol fast blue, which stains myelin, and the absence of staining highlights the myelinating lesions present within histiocytes, demonstrates ingestion of myelin as seen in MS. And the trichrome and reticulin stains both delineate the sarcomatous components of gliosarcomas. A reticulin stain demonstrates the connective tissue around the acini of the normal pituitary gland and features a feature that is lost in peanuts or adenomas. This table shows the immunohistochemical stains and the staining patterns. An individual tumor may lack a marker that typically represents representative of its type. However, a positive stain is typically more significant than a negative stain. So glial fibrillary acidic protein, or GFAP, is a polypeptide, and it would be unusual for a metastatic lesion to demonstrate staining for GFAP. However, GFAP expression may be limited to certain subsets of GBMs. The S100 protein is a low molecular weight calcium binding protein that stains a variety of tissues, including glia, neurons, chondrocytes, stellate cells of the adenohypophyses and the myoepithelial cells. And the primary uses in neuropathology include to support the diagnosis of metastatic melanomas, and in the peripheral nervous system to confirm the diagnosis of schwannomas or neurofibromas. Clinically has been measured in serum. The cytokeratins, or high and low molecular weight, the different keratin staining combinations can be used to suggest possible sites of origin of metastatic tumors. Epithelial membrane antigen, these are stains the cell membranes in many carcinomas and is useful to distinguish hemangioblastomas, where it is negative, from metastatic renal cell carcinoma, and also meningiomas typically demonstrate positive staining, as do ependymoma. And the MIB1, which is also known as the monoclonal mouse antibody Ki67, is expressed in all phases of the cell cycle except G0, and it is often used in lymphomas, endocrine tumors, carcinoids, etc. And this stain can be used to compute a semi-quantitative score, and a high MIB1 labeling index denotes a high mitotic activity, which often correlates with the degree of malignancy. Neuroendocrine stains in neuropathology, it is utilized in the central neurocytoma, medulloblastomas, pineocytomas, ganglion cell tumors or paragangliomas, and choroid plexus tumors. Metastases that are positive for neuroendocrine stains include small cell carcinoma of the lung, which is most common, and malignant pheochromocytomas and Merkel cell tumors. It includes chromogranin, which stains the synaptic vesicles, perhaps less commonly utilized than synaptophysin in the primary CNS tumors. Synaptophysin stains synaptic vesicles, and it has a higher sensitivity but a lower specificity than chromogranin, and it is often positive for central neurocytomas, which typically lacks chromogranin staining. There's also the CD56 neural cell adhesion molecule and the neuron-specific enolase. There's the cluster of differentiation, or CD markers, and these are metastases that are positive for neuroendocrine stains include small cell carcinomas of the lung, malignant pheochromocytomas, Merkel cell tumors, as I would have mentioned in a previous slide, and metastatic small cell tumors of the brain. Staining positive for neuroendocrine stains are almost all due to lung primaries. This table here would summarize the molecular alterations in major CNS tumors. In the WHO CNS5 in particular, molecular genetics plays a central role in the classification of CNS tumors. And here we can see the key molecular alterations that are involved in the diagnostic classification of the major CNS tumors. So the use of tumor markers clinically, I'll just make mention of a few. Human chorionic gonadotrophin, or HCG. It is a glycoprotein, and higher levels are diagnostic of cerebral mets from uterine or testicular choriocarcinoma or primary choriocarcinoma of embryonal cell carcinomas of the pineal or suprasellar region. Alpha-fetoprotein is normally a fetal glycoprotein and initially produced by yolk sac and later by fetal liver. CSF AFP is elevated in some pineal region germ cells in 16 to 25% of patients with testicular tumors and develop cerebral mets, and elevated CSF AFP levels are reported in some. And CEA, it is a glycoprotein normally present in fetal endodermal cells, and it may be normal even in CEA secreting cerebral mets if they don't communicate with the subarachnoid space. Only carcinomatous meningitis from lung or breast CEA consistently elevates CSF CEA in the majority of patients. And lastly, the S100 protein, serum S100 protein levels rise after head trauma and possibly after other insults to the brain, and the levels may also be elevated in Creutzfeldt-Jakobsen disease. So these are my references, and this brings me to the end of this first lecture in the series. Next week, we'll be continuing with genetic tumor syndromes and involving the CNS. Thank you and good night.